With fluid, yes, with fluid. Dumb. Don't be dumb. So let's talk about tachycardias. First of all, why is the patient tachycardic and what type of tachycardia? Sinus tachycardia is always compensatory until proven otherwise. Always. Sinus tachycardia is a symptom of an underlying problem always until proven otherwise, and you're not going to be the person that proves otherwise. Right? Patients might have a problem with sinus tachycardia and they need to go see a cardiologist. So, we always assume, right? People say, assume makes an ass out of you and me. That's so stupid. We always assume that sinus tachycardia is compensatory or is the result of an underlying problem until, right, proven otherwise, or an underlying problem that we may be able to fix. So please don't try and slow down sinus tachycardia. A few years ago, there was a child in southern Arizona between Phoenix and Tucson that got picked up by a flight crew in the middle of the summer who proceeded to electrocute him multiple times for his SVT. That turned out to be sinus tachycardia because he was severely dehydrated and hyperthermic. And guess what? He died. So, little children's, a child's SA node has the ability to fire at very rapid rates and compensate much better than some old asshole like me. If my heart rate's in the 170s, might be a problem, right? Probably not compensatory. Yes.
Sorry to backtrack. Do you know that child's pressure by chance?
Do I know the probably was hypotensive because he was so dehydrated.
Yeah, just curious if you knew.
Right, and hyperthermic. No, I don't know the number. The whole point of me telling you that is do not confuse sinus tachycardia with SVT. Do not confuse sinus tachycardia with SVT. Much harder, much more important than in children than adults. Adult is usually easy to figure out that it's sinus tachycardia. Sometimes in kids, you need to do a little investigating. Why is this kid's heart rate 160? Well, he's been nauseated and vomiting for 3 days. Has he had diarrhea too? Yes. Has he been keeping fluids down? No. Is this compensatory? Maybe. Can we try little fluids? Yes. Little. A lot. Little. Listen, sinus tachycardia due to volume depletion, such as dehydration, will respond very quickly to even small amounts of fluid. Very quickly to small amounts of fluid. SVT should not respond to fluids at all. Will probably not respond to fluids. What is the problem with somebody in SVT? What's the potential problem with somebody in SVT?
Fill time of the heart.
Say it again.
Fill time of the heart.
Good. Yes, right? The fill time of the heart. So somebody who's in SVT, the heart is beating so fast that it's not able to fill with blood. So what is the ultimate result of that? What is the problem? Decreased what? Cardiac output. So we are treating the SVT when they're unstable to fix cardiac output, not necessarily to fix the heart rate. We are fixing the heart rate to fix the cardiac output problem. But we're treating the cardiac output problem, we're not treating the heart rate, right? Always think about the problem that you're treating, the underlying problem with the patient. So somebody's hypotensive. What's causing the hypotension? Oh, the heart rate of 180. Okay, let's reduce the heart rate so we can treat their hypotension. Don't think of it as we're treating the heart rate. We're treating the hypotension. We're treating the reduction in cardiac output. So once you figure out that it's sinus tachycardia, then let's give the patient some fluids. How much fluids? Enough. I don't know, right? Depends. Depends on what their problem is. Somebody who is severely dehydrated, an adult, bless you, might take 2, 3, 4 liters. Depends on how dehydrated they are. Children who are severely dehydrated, you might end up using 50 or 60 milliliters per kilogram to fix their volume depletion. This is much different from someone who's bleeding out. We give that person too much fluids, then what happens? We just push what little hemoglobin they have even further apart, and we make them more hypoxic by giving too much fluids. So different problems. Bleeding versus volume depletion due to dehydration or sepsis or whatever. What happens in sepsis, aside from somebody can be volume depleted because they become dehydrated because they're sick, but what else happens in sepsis? What happens to the blood vessels in sepsis? What do the endotoxins do? Yes, causes them to become dilated, right? Somebody who is in septic shock can have mass vasodilation. Why do you see modeling in children with sepsis? You can see it in adults too, because they've got vasodilation. So the tank gets bigger. What happens to cardiac output? Drops. And the person's also been sick and had a fever for however many days. And maybe diarrhea, I don't know, vomiting. They're dehydrated. They're dehydrated, and now their tank has gotten bigger. So now they're severely volume depleted. So we need to give them fluids. I don't know that have I ever lectured to you guys before?
No.
I don't think so. I'm going to give you a quick way. I learned this from an intensivist when I was at Arabic. We used to have physicians come in and educate us all the time. This is a great way to tell if someone is volume depleted or volume overloaded. Easy, quick way. You don't need a Swan-Ganz catheter to look at intravascular volume. You just need a blood pressure. What is a pulse pressure? What is pulse pressure? Yeah, difference between systolic and diastolic. Normal pulse pressure is 35 to 55. Think of speed limit. Well, we don't really have many 55 speed limits anymore. But Sarah Disney and I remember when speed limits were 55 on the freeway, right? 55 on the freeway. 35 to 55. What did you say?
Micro horses.
We had horses that ran fast, 55 miles an hour. So guess what? If our pulse pressure is less than 35, we have a patient that is volume depleted. Oh, if it's greater than 55, they are volume overloading. So this intensivist said, for years I would put Swan-Ganz was a type of central line that they would put in patients and they could monitor intravascular fluid levels. And he said, for years I'd put Swans in patients and I'd monitor their fluid levels. He said, and I finally figured out, all I need to do is look at pulse pressure. So if you have a patient who has a pulse pressure less than 35, I don't care what their blood pressure really is. They may be hypertensive and have a narrow pulse pressure. They may be hypertensive and volume depleted at the same time. And sometimes people are a little high on blood pressure side. Think maybe they've got hypertension anyway. And now they're volume depleted. So they're hypertensive and volume depleted at the same time, and you give them some fluid and their blood pressure actually comes down. Amazing. Well, guess what? Because the heart isn't trying to compensate as much, so blood pressure comes down. I remember my mom calling me one day. My dad, at the time, when he was alive, she called me and she said, "Dad's not acting right. said, well, take his blood pressure. And she said, oh, yeah, his blood pressure is 92/70. Oh, really? Well, no wonder he's not feeling well. First of all, he hadn't been drinking water, and he ended up taking an extra blood pressure medicine that he didn't realize. Volume depleted. In Arizona, I would bet a majority of patients every summer run a little dry. All of us in here right now could probably get at least a liter of fluid and be just fine when we pee a little bit extra later on. Right? That wouldn't put us into volume overload. So, is this not a simple way to tell if your patient's volume depleted or volume overloaded? Right? Patients with congestive heart failure and pulmonary edema are not always volume overloaded. Sometimes they just have the problem of the volume being in the wrong place. In the wrong place. Patients with right-sided failure that have a bunch of pulmonary edema doesn't mean they're volume overloaded. Might just mean that their right heart is failing and they get fluid backing up. So let's look at the pulse pressure. Very simple way to tell you if your patient needs fluid. Bless you. We should always be able to justify why we do what we do. We don't just give somebody 100, 200, 300 mLs for no reason at all. You better have a reason. If you start your IV and you say that you're running it at TKO, and when you get the patient to the hospital, 300 mLs have run in, you're not running it at TKO, and you really should be able to explain why you gave that patient 300 mLs of fluid. In the grand scheme of things, is somebody getting 300 mLs of saline a bad thing? Probably not. Probably not. Unless you push them over the edge, right? They already had a liter of fluid backed up, and now you put them into pulmonary edema because you accidentally gave them too much fluid. I'm going to tell on myself, learn from my mistakes. I picked up a patient who had missed 3 of his dialysis appointments. Younger guy, kidney failure, obviously, on dialysis 3 times a week. He missed an entire week of dialysis because he wasn't feeling well. And now he really wasn't feeling well, and his belly was huge. He had ascites. So started an IV on him just to be safe, right? I don't want him to code and not have a line. So started an IV, sitting in the back, not paying much attention, doing my chart. We get him to, this is going from Buckeye to Thunderbird. That's where he wanted to go. We get him to Thunderbird, and I look up, and I had just hung a 500 ml bag. I hadn't even hung a liter on him. So we used to have 500 ml bags, and I would hang them when the patient really didn't need fluids. And I look up, and there's hardly any fluid left in there. Somehow, my little clamp had vibrated open during the transport. And guess what? He was starting to have severe difficulty breathing. I put him into pulmonary edema with less than a liter of fluid because he already had so much fluid backed up. So obviously I told on myself. It was the right thing to do. Hey, this patient got 500 mLs and I didn't mean to give him that, but that's what happened. That's why he's having the trouble breathing. And the nurse was like, okay, that makes sense. Bad medic. And I learned from then on, always pay really close attention to my IV running. So remember, whatever you do to the patient, you need to be able to justify why you do it. Well, I'm starting an IV. Why are you starting an IV? Just to start the IV. Well, no, bullshit. If you're starting an IV, there better be a reason why. Prophylactic. What do you mean prophylactic? Well, I'm worried that the patient's condition would change, that I might need IV access. That's reasonable, depending upon the problem. A kid with a broken arm. Why'd you start the IV? So I could give pain medicine. Makes sense, right? Makes sense. Do all patients need IVs? No. Not all patients. Do all patients that go to ERs need IVs? No. So think about whenever you do something, you should be able to justify it. Start looking at people's pulse pressures. What's great is looking at pulse pressures in normal healthy people, because that will really tell you if they're volume depleted. And guess what? If you get a pulse pressure of 38 or 40, are they on the low side? Yes. Could they use some extra volume? Yeah, probably. Probably. So pay attention. Take blood pressures. Yes?
Real quick, if you can repeat, you said patients with blank can be in volume, don't necessarily need it, or are in volume.
Patients who have heart failure might not be fluid overloaded. They might have their fluid just in the wrong location. So somebody who's got left heart failure, they can have fluid that backs up to their lungs. It doesn't necessarily mean they're volume overloaded. It just means the heart isn't pumping effectively enough to move the fluid out of the lungs. Thank you.
I'm sorry.
Right? Somebody who's in right heart failure without left heart failure, what's that called? Cor pulmonale. Right heart failure without left heart failure is cor pulmonale. They usually have dependent edema. Doesn't mean they're fluid overloaded. Could just mean the fluid's in the wrong location because the right heart is having a hard time pumping it back through to the lungs. So it's building up in the body. So look at your pulse pressure. Don't be afraid to give somebody with dependent edema fluids if they need fluids, right? The right heart, somebody in right heart failure can end up depending upon, their life could depend upon you giving them fluids to create preload, right? Somebody who's having a right heart MI, they need fluids, right? They need that preload to push their blood through to the lungs, so you better give those patients fluids. So just keep in mind, a volume problem might not be, or a fluid problem might not be the amount, it could be just that it's located in the wrong place. Somebody who, you listen to their lungs and they've got crackles in a certain area, and they've been sick for 2 days, and they've had a fever, and oh what, guess what, they got pneumonia. Give them fluids. That's not going to affect those crackles. Completely different process, right? One's infection versus left heart failure is left heart failure. So don't withhold fluids from somebody who's sick with pneumonia because you hear some crackles in one part of their lung. So any questions about tachycardia? So we talked about sinus tachycardia. It's compensatory. What's it being compensatory for? Well, are they low in volume? If they're low in volume, give them some fluids. A patient has a pulse pressure of 30 and a heart rate of 112. Give them fluids. The heart rate is compensatory for their volume depletion. Somebody has a heart rate of 170. Let's get back to SVT versus sinus tach. If you take my fat ass outside and try and run me around this building, we might get my sinus node to be at 174 for a short period of time. If I run my fat ass around this building and it stays at 174 for 20 or 30 minutes, we've got a problem, and it's probably not sinus anymore. I probably put myself into SVT. So think about the history of the patient when you're trying to decide, is it SVT or is it sinus tach? Do I see a P wave? I don't know if it's a P wave. Is it a P wave, but is it a sinus, or is it atrial tachycardia? I'm not quite sure. The history. It all boils down to history. What were you doing when this started? I was watching, you got a 70-year-old now. I was watching Wheel of Fortune, and Vanna came out in her really low-cut dress, and I got all excited. And all of a sudden, I felt my heart pitter-pattering. Probably SVT. Oh, I was gardening outside all morning long. Maybe volume depletion. And then again, what are we going to look at? Look at their pulse pressure. Now, somebody with SVT, what will their pulse pressure probably be? Probably be low. So that doesn't mean they're volume depleted. So go by their history. What were they doing? Was this something that started all of a sudden? So a few years ago, during COVID, I was going to the gym because my gym was one of the few gyms that stayed open. So I was going to the gym a lot, trying to lose a bunch of weight. I lost 84 pounds a few years ago. So if anybody wants to learn how to lose weight, come talk to me. I don't know, of course I gained back about 28. So I'm on the weight loss kick again. But I was working out every single day of the week. for a few months, I worked out 7 days a week. And I was taking this pre-workout drink called C4. Popular. But I didn't get the C4 off the shelf at like Fry's or whatever, right? I actually ordered it from the company, or I get it at GNC. But I got the ultimate one. It wasn't the normal one I took, but I ended up getting the ultimate one, and I didn't realize how much caffeine it had in it.
Were you itchy?
And so I wasn't feeling really good. I started not feeling good one afternoon, and I was supposed to go, I was doing injections, COVID injections at State Farm when they were doing it there by the arena, or by the stadium. I'm like, I'm not feeling good. Do I really want to go and stand outside for 8 hours? I'm like, yeah, whatever, I'll do it. So I went, did the shift, I came home, I'm like, wow, I'm really not feeling good. And for some reason, I just decided to check my pulse. I'm like, oh, that's weird. Huh, I wonder if I'm having PACs. It's really irregular. So I went and grabbed my Apple Watch, and I put it on, and I did my little EKG, and I was in AFib. And I had put myself in AFib, and I really didn't feel well. And I thought, oh shit. And my rate was, I was AFib with RVR, so my rate was bouncing between 120 to 160, right? Enough to be that I probably should have gone to the ER and be treated, but I didn't. I stayed home. Because I'm a paramedic. What am I going to do? I'm stay home. I sent Sean a text message. Hey, Sean, what do you think? He's like, you need to go to the ER. I'm like, yeah, not so much. Don't think so. But just wanted you to know in case I don't show up at work. It went away, and then I never took the C4 again. So that was stimulant-induced AFib. I've never had AFib since. So when you've got somebody who has a rapid heart rate, you need to look at the history and figure out what they've done, what they've been doing. Was this something that started immediately, or is it an acute problem, or something that started slowly? Again, get the history and then treat appropriately. Please don't give somebody with sinus tachycardia adenosine. Now listen, you give them adenosine by mistake, guess what? The sinus tachycardia should just come right back. I worked with a nurse once. I used to work as a psych tech part-time because I found this staffing agency that said, oh, you're a paramedic? Yeah, you can be a psych tech, and just for fun and extra money, and I got paid like daily to do it, so yeah, I'll go sit with people that are a little crazy and make some money. What? So, I forgot the point of my story.
You said you were
The job,
an
the site,
agency.
Yeah, psych tech. Why am I telling you that I was a psych tech?
You were talking about adenosine.
Sinus tech.
Yes, oh yeah, I worked with
Adenosine.
this nurse who told me that she originally thought she wanted to be an ER nurse. And when she was in class, she got to push adenosine when she was doing one of her clinicals. And she said she said, you know, they're supposed to have a little period of asystole. She said the patient went asystolic and never came back and died. She said that's why I became a psych nurse. So that's rare, right, that could happen. Normally the sinus mechanism kicks back in. So please don't give adenosine when you shouldn't be giving adenosine. Right? So if they're in sinus tachycardia, fix the underlying problem. What else can cause sinus tachycardia besides volume depletion? Anxiety, caffeine, right? Anything that increases dopamine release in the body.
Infection.
Excitement, infection, right? Adderall. Right, way back when I was young and in college, we used to take, hey Sarah, remember this? Revive with Vibrant. So they're little caffeine pills, and people would take them to stay awake and study or whatever, right? Stimulant, so it could cause tachycardia, yes.
Might be a dumb question, but
Probably.
would that be the only shockable asystole? Is if you induce
No,
it?
no, don't shock asystole.
Do they push
CPR it, they're dead. They're dead, CPR. The CPR, if you oxygenate the cells, they should come back on their own. They should come back on their own. I don't think you're gonna make them any more dead by shocking them. If you wanna call it fine V-fib and you zap them just because and they come back, yay. But studies prove, we used to shock asystole occasionally. If all else fails, try it, but by the time we would try it, they wouldn't come back anyway. So the studies showed that shocking, defibrillating people in asystole didn't work. So consider your H's and T's. Now really, if you look at ACLS and you look at the text, the H's and T's really are supposed to be considered for two situations, asystole and PEA. We tell you to always consider H's and T's anytime there's resuscitation, but mainly for asystole and PEA if there's a reversible cause that you can fix. So one of your H's and T's. So don't confuse sinus tach for SVT. And how do we fix the SVT? So if they are stable, they get what? Medications. Don't give them the cable if they're stable. Right? Please don't shock somebody that's stable. Why don't we give, why do we teach you not to give adenosine to somebody who's unstable?
Takes time.
Takes time. That's really the only reason. It takes time to get that IV. It takes time to get your adenosine. It takes time to give it. Where shocking somebody who is hypotensive and in SVT, shocking them takes care of it right now. So what are we trying to do though by shocking them?
Convert the rhythm.
Yeah, I love the physical activity there. So we're trying to convert the rhythm so they don't become what? Dead. So if somebody's in SVT and hypotensive long enough, how well is the heart oxygenating? Not well. What did we talk about earlier? The heart becomes hypoxic enough, what rhythm will it go into? V-fib, V-tach, right? A more lethal rhythm. So fix the SVT when they're unstable quickly. Can you use adenosine in unstable SVT? Yes, you can, and lots of physicians in the ER will do it. And that's their choice. And it will work. Just remember, you're taking a chance that they could die by the time you get that adenosine in them. If they already have a line, and you got the adenosine right there, whatever, go ahead. Try it. But that's why we teach you, that's why AHA says cardiovert, sync cardiovert for unstable SVT or VTAC, because we don't want them to become dead before you can get a medication in them. I'm going to show you this video by Dr. Matu, and it talks about amiodarone, and it's going to blow your mind. So, Dr. Matu is a cardiologist and he's emergency medicine. How come we can't hear it? Now let's
Give him fluids to increase the volume.
Oh, bastard. Are you guys ever able to hear the volume in here?
No.
Never?
Not like really well.
It takes a while for them to get it to work.
You gotta drop a few F-bombs first.
Mm-hmm. Slap some things.
I don't know why, the volume's turned up all the way.
Automatic. And the pacemaker, you know, I think
You're
it's
right.
just jolt.
The audio mute is turned off, so it's not muted.
I'm sorry, I'll be.
Yeah, no, it is.
Oh boy.
No, I agree. No, I was like, oh, this is me. And I was like, hey, can I take this off?
Is the world in here?
want to know why?
Okay.
Well,
Okay.
I don't know.
She tried. You feeling it?
I think it works.
All right, well, greetings everyone.
If you're really quiet, can you hear it?
No.
There's subtitles.
Turn on the YouTube subtitles.
Definitely get too much space.
All right, hey, let's be quiet and see if you can hear this. It's actually important information.
With this talk, as many of you know, that there's a lot of great medications that have been black boxed over the past handful of years for various reasons. And just to be a little controversial, I'm going to suggest, why hasn't amiodarone been thrown into the black box as well? Let's briefly talk about amiodarone. As we all know, amiodarone was first really introduced into popular medical use back in 2000 when the American Heart Association endorsed the use of amiodarone for cardiac arrest. In 2000, AHA guidelines put amiodarone as a class 2B rating and dropped lidocaine, which had previously been considered the drug of choice, to an indeterminate rating. And so the popular marketing at the time was that amiodarone should be considered the preferred drug in cardiac arrest. And because of that, everyone fell in love with amiodarone and started using amiodarone for everything. People said, hey, you know, if your patient has a PVC, put them on amiodarone. Put their family members on amiodarone. Put the nursing staff on amiodarone and the patients in the next room, put them on amiodarone also. But when we start taking a look at the evidence, amiodarone may not be quite as good as we were all led to believe. First point, cardiac arrest. In 2005, the American Heart Association finally came out and said, well, you know, in 2000 we said amiodarone was really great. It turns out that it doesn't actually work. And this is a quote from right out of the American Heart Association guidelines in 2000, saying there's no actual evidence that any antiarrhythmic works when patients, human patients that is, are in cardiac arrest. You use it in animals, I suppose, but human cardiac arrest, there's no drugs that have been found to be effective in cardiac arrest. So you can use amiodarone if you want, but it doesn't really work. And now in 2012, we know it's all about ELS, not ALS. Drugs don't make much of a difference. But it took 5 years before the American Heart Association actually published this. And a lot of people were being, had their elbows and arms twisted into using amiodarone. What else? This is not commonly taught, but amiodarone should really be avoided in patients that are pregnant. Amiodarone is a class D antiarrhythmic, which means it's clearly considered to be harmful. It is probably the only class D antiarrhythmic. Beta blockers, calcium channel blockers, lidocaine, propionamide, all the rest of them are generally considered Bs and probably more commonly Cs. Why is amiodarone considered a class D antiarrhythmic? Well, it's because it causes fetal hypothyroidism, intrauterine growth retardation, fetal bradycardia, prematurity. There's a relatively high iodine content in amiodarone. The general recommendations are do everything possible to avoid using amiodarone, even shock the patient. Cardioversion and defibrillation are considered far safer in ventricular fibrillation and pulseless VTAC compared to amiodarone. So stay away from amiodarone in all stages, not just third trimester, but all stages of pregnancy. What about atrial fibrillation with pre-excitation, or Wolff-Parkinson-White syndrome? It's also not commonly taught, but is not really considered safe. There's a 1280 kg sent to me by person that runs Team at Home, Dr. Rick Nunes. He had a relatively young patient that came in with this very rapid wide complex tachycardia. The QRS complexes are changing morphology. In some places, the rate's approaching 300 beats per minute. That's your classic atrial fibrillation with WPW. The AHA guidelines suggest the possibility of using amiodarone. It's not really a safe drug. And here's how we learned this the hard way. This is a patient with AFib and WPW. we gave the patient amiodarone, and the patient went right into ventricular fibrillation. Fortunately, we shocked him out of it, but then we went and took a look at the literature, and if you look at the world's literature, there's really no good supporting evidence from research studies or case series saying that if you have rapid AFib with WPW and you use IV amiodarone, that there's really great outcomes. In fact, this is just a handful of the articles that are out there in the world's literature indicating decompensation after patients with rapid AFib and WPW were given IV amiodarone. The world's literature suggests at most that it's probably not a good drug. So stay away from AFib. Stay away from amiodarone in AFib and WPW. It actually makes sense when you think about the mechanism of the drug. Amiodarone has beta blocker and calcium channel blocking effects. In other words, amiodarone is part AV nodal blocker, and we know that AV nodal blockers are deadly in AFib and WPW, so stay away from amiodarone. What else? Well, when amiodarone first came out, people started saying, well, what about amiodarone if there's a prolonged QT? It doesn't really affect the QT much, does it? What about PVCs? None of us like seeing PVCs. PVCs perhaps predict ventricular tachycardia or VFib. So if you see PVCs, let's put them all on amiodarone and see what happens. Well, we once again learned the hard way that amiodarone is not good for these patients. Here's an alcoholic who came in with palpitations. He's got, as you can see, a lot of ventricular ectopy. You might also appreciate that he's got a somewhat prolonged QT. That was missed. Everyone just focused on the ventricular ectopy. He had a prolonged QT because he was, just like all alcoholics, hypomagnesiemic and also a bit hypokalemic. The patient got amiodarone to get rid of the PVCs, and during the amiodarone bolus, he went right into Torsade. No big surprise there. Here's another patient, 66-year-old woman who presented with chest pain and a pretty good story for admission. QTC you see up here is 464 milliseconds, is pretty normal. But there's PVCs here, and the admitting team wasn't happy to see PVCs. So the admitting team said, you know what, we're gonna get woken up by the nurses all night. If we don't get rid of these PVCs, let's try some amiodarone. So they start the patient on amiodarone. Sure enough, the PVCs are gone. They didn't happen to notice, however, that the QT is now a lot longer. QTC is 562 milliseconds, and it turned out that they did get woken up that night by the nursing staff when the patient went into this. So this was pretty much their expression. The patient went into Torsade. So they quickly stopped the amiodarone, put the patient on a magnesium infusion. QT came to 480. Bottom line, please remember, amiodarone is part sodium channel blocker also, and it's going to prolong the QT. Here's another case where we learned this the hard way. 55-year-old man who's taking methadone. We know that methadone prolongs the QTC. His QTC is 551 milliseconds. Normal being less than 490, less than 480 or so. He's got a very, very prolonged QT, and he was intermittently developing runs of Torsade. In fact, his wife brought him into the hospital because he was having occasional syncopal episodes. Well, they shocked him out of that episode of Torsade. Now you got to put him on something to prevent him from going back into it. What did they chose to do? They chose to use amiodarone. So he gets started on amiodarone, and now his QTC increases to 653 milliseconds, and no surprise, he went right back into Torsade and had to be shocked multiple times. And finally, we got him out of it, stopped the amiodarone, started him on a magnesium infusion. So again, they learned the hard way that amiodarone prolongs the QT and is not safe just for PVCs. It's not safe for anyone with a prolonged QT. What else? Why complex tachycardias that are associated with hyperkalemia? This is not a safe time to use amiodarone either. What a lot of people may not realize is hyperkalemia poisons the sodium channels. So the last thing you want to do is put these patients on a medication that is a sodium channel blocker in and of itself. So hyperkalemia or any drug toxicity prolonging the QT or blocking sodium channels, you stay away from amiodarone. Once again, let me show you how we learned this the hard way. This was an inpatient who was hyperkalemic. Now the physicians didn't know that the potassium was 9.2. All they saw was this wide complex tachycardia. The morphologies are changing a little bit, but I don't think they really noticed that. They just said this is a wide complex tachycardia. and the patient was relatively stable, so we said, let's use the medication. They put the patient on amiodarone, and he went right into asystole and died. Later, they discovered that his potassium was 9.2. Amiodarone is not safe in the presence of hyperkalemia. Here's another case. Patient has a wide complex, kind of a bizarre looking tachycardia. The rate's 105. This was due to hyperkalemia as well. Unfortunately, the physicians didn't realize it. They said, wide complex tachycardia, we gotta get rid of it. Let's try some amiodarone. So an amiodarone bolus was given over 5 minutes, and towards the end of that 5-minute bolus, the patient had a Brady asystolic arrest. And after they pronounced the patient later on, they discovered that the patient's initial potassium with his top rhythm strip was actually about 8.0. So hyperkalemia poisons the sodium channels and can mimic VTAC with wide complex tachycardias. If you suspect hyperkalemia, don't use amiodarone. You're going to knock out those sodium channels. There's another time when amiodarone can be dangerous. This is a wide complex tachycardia, but in this case, you'll notice the rate is not that fast. The rate here is only about 110. When you see a wide complex tachycardia with a rate that's under 120, don't call it VTAC. This is not VTAC. This is actually accelerated idioventricular rhythm. This is a patient who recently got thrombolytics for a STEMI, now develops this rhythm. This is called AIVR, or accelerated idioventricular rhythm. This is a reperfusion arrhythmia. When you see this rhythm, you should be happy. Give your patient a high five. It means your artery has opened up because of the thrombolytics that you've given the patient. Fortunately, the physicians taking care of this patient misdiagnosed this as VTAC. They didn't realize that you have to have a heart rate of at least 120 before you call something VTAC. They call this patient VTAC because the heart rate's only about 110 or so, and the drug they chose to use was amiodarone, and it put this patient right into asystole, and the patient could not be resuscitated. When you see this rhythm, you simply put your hands in your pockets and observe the patient. You don't treat this patient with lidocaine, amiodarone, procainamide. None of those drugs should be given. And again, they panicked, they called it VTAC, and they used amiodarone. Amiodarone is deadly with accelerated idioventricular rhythm. Just observe the patient. But you know what? We still have amiodarone for ventricular tachycardia, right? Amiodarone's got to still be useful for ventricular tachycardia. Well, maybe not. The amiodarone was considered the drug of choice back in the last decade, the early part of the 2000s, because everyone thought, well, amiodarone is good for ventricular fibrillation. It's got to be at least good for ventricular tachycardia as well. Well, they ended up studying it. Isn't it terrible when you study things and find out that what you thought as dogma turned out to not be true? And this is one of the studies that got put out. Stable patients with ventricular tachycardia were given amiodarone, and it only worked in 29% of cases. This is published in Annals of Emergency Medicine. 29%, that's right around where lidocaine is. Remember, we got rid of lidocaine when amiodarone came around. Turns out amiodarone is only about as effective as lidocaine, 29%. In that same issue of Annals of Emergency Medicine, Richard Cummins published an editorial saying, well, you know, back in 2000 when we said amiodarone is this great drug, even for VTAC, we were actually making that claim based on older research, which even then showed amiodarone was only effective in about 40 to 60% of cases. So amiodarone's never been that good for stable VTAC. This study says 29%. Let's move forward a couple of years. In 2008, European Journal, Emergency Medicine Journal, did a similar study. They looked at stable patients with VTAC. They gave them amiodarone, the so-called drug of choice, and it was only effective, once again, in 29% of cases. Well, some people might say, well, amiodarone is great because if it works very quickly. Maybe not, because in this study, they found that even when amiodarone worked, only 15% of the time did it convert the patients quickly, within 20 minutes. So it's neither fast nor effective. So based on studies like this, back in 2006, take a look at these organizations, American College of Cardiology, American Heart Association, and the European Society of Cardiology got together. Now, anytime these three major organizations get together and say something, it's worth listening to. Got together in 2006 and put together what they refer to as an executive summary. essentially talking about how we should be taking care of patients with ventricular arrhythmias. Now, a lot of this is a bit more relevant to the cardiologists, but the one main point that these guys came up with in 2006 that's relevant to emergency medicine is procainamide. Procainamide is back. They said procainamide is the drug of choice. This is in 2006 in Circulation, the main journal of the American Heart Association. Why this didn't get a lot more publicity, I'm not really sure. These are quotes from right out of this international executive summary. IV amiodarone is not ideal for early conversion of stable monomorphic VTAC. IV procainamide is more appropriate when early slowing of the VTAC rate and termination of monomorphic VTAC are desired. Amiodarone can cause hypotension, bradycardia, and prolongation of the QT interval. Again, that's not well publicized, but they talk about this in this particular Circulation article. They said IV amiodarone is reasonable for patients with sustained monomorphic VTAC that's hemodynamically unstable, refractory to conversion with countershock, or recurrent despite procainamide or other agents. So what they're saying is that amiodarone can be used after you've already tried other agents first. It's not the ideal agent. Well, finally, in 2010, the American Heart Association finally caught up with the literature and downgraded, or rather, put procainamide as a higher class rating than amiodarone based on the literature that we already have. Procainamide is class 2A and amiodarone class 2B for stable patients with ventricular tachycardia. Once again, key point, procainamide is back in line. And for those of you that are young and have never used procainamide before, procainamide is here. Start using procainamide. It is the first-line drug of choice if you have stable VTAC. Quite honestly, don't hesitate to just sedate and shock these patients. I think we've really gone too far away from shocking patients. Sedate and shock patients is faster, most reliable, quickest way of taking care of patients with stable VTAC. But if you really don't want to cardiovert somebody, and you want to use a drug for stable VTAC, procainamide is the way to go based on literature. Remember, amiodarone appears to only be effective in about the same numbers as lidocaine, 29% or so. Not that great. So, quick summary. It's important to remember this. Amiodarone is not ideal for everything. In fact, the studies say that amiodarone is dangerous in a handful of cases. It's dangerous in pregnancy, dangerous in AFib with WPW. For prophylaxis against VTAC, when you see PVCs, it's dangerous. If you have a long QT, dangerous. Hyperkalemia, dangerous. And accelerated ventricular rhythm, amiodarone is dangerous as well. And there's a few other cases where it may not be dangerous, but poorly effective or ineffective. In cardiac arrest, it doesn't work. And in patients with stable VTAC, it doesn't work most of the time. Procainamide is better. And the final key point I'll just leave you with is amiodarone is not a cure-all. Back in 2000, amiodarone was force-fed to all of us as the greatest drug ever for patients with ventricular arrhythmias. It's not a cure-all, and in fact, it has some serious limitations and some dangers associated with it. So, if you want to use amiodarone, fine, but just be very, very careful. Make sure you know all the limitations associated with amiodarone, and make sure you know those times when amiodarone can actually be deadly. So my question once again, where is the black box for amiodarone? It really should be in there. We've got better drugs that are safer. Final reminder once again, please remember the Crashing Patient Conference is going to be.
So what do you guys think about amiodarone now?
Why do we still use it?
Why don't paramedics in Arizona carry procainamide? I don't know.
Why can't we just sedate and shock them?
So there's another listen, he has quite a few videos. I recommend watching him. Very smart man. He always backs up what he says with studies, with science. In this video, I wish I would have found the other video to show you. But in this video, he did not talk about slow VTACs and how to treat like a VTAC that you see with a rate of 110. He talked about that really being accelerated idioventricular. Well, you would never give a patient in a ventricular rhythm a drug that would knock that rhythm out, right? AIVR, if you gave lidocaine amiodarone, what's it gonna do? Put them in asystole. It will keep that ectopic focus in the ventricles from firing. Oh, you'll kill him. He showed you the example of that patient that died, right? They gave amiodarone, the patient went asystolic. In this other video, he says patients with slow VTACs, less than 120, you need to think either toxicology problem or a metabolic problem. And you have 2 drugs in your drug box that can assist with those problems. What are the 2 drugs that you carry? Sodium bicarb and calcium. Yes. Somebody's hyperkalemic. Shove the potassium back in the cell with calcium. Somebody's got some sort of metabolic, or somebody's got some sort of toxicologic problem. Give sodium bicarb. We all could get a dose of sodium bicarb. We could all get 1 milliequivalent per kilogram of sodium bicarb in here. And guess what? If we didn't eat it, what would it make us do? It would make us pee, right? It would make us pee a little bit more. Not going to kill us. You're not going to make a patient become alkalotic by giving 1 dose of, I'm not talking about an AMP. People say, oh, give an ample bicarb. No, give the correct dose, 1 milliequivalent per kilogram. We're not going to put the patient into alkalosis by doing that. But guess what? If their problem is toxicologic and they got a slow VTAC, you can save their life. If they're hyperkalemic, also, everybody in here could get a dose of calcium. Not going to kill us. But if we're hyperkalemic, it could save your life. So I'm teaching you this, I'm showing you this video, not saying go against AHA guidelines, not saying never to use amiodarone, but I want you to think as a paramedic. We're not treating the rhythm, we're treating the patient. What's wrong with the patient that's causing that rhythm? What's wrong with the patient that's causing the rhythm? And that should always be, that's why we teach you consider H's and T's for every cardiac arrest situation. What's wrong with the patient that's causing them to be in the rhythm they're in? So don't treat the rhythm, treat the patient. You see a slow VTAC and the patient's stable, please don't give them amiodarone. You get these guidelines and you get this offline stuff and CARES. That is not an absolute have to do it. It's what you can do. You don't have to do it, it's what you can do. So make a good, educated decision, and if you want to do it, then you should do it. But think about it. Slow VTAC, maybe calcium and bicarb would be the better answer than giving amiodarone and killing the patient. Wouldn't that suck to give amiodarone and watch the patient go asystolic and just die in front of you and not be resuscitatable? Yeah. And then you, after watching this video, you know now, oops, I killed the patient. I actually killed the patient. So I knew at the time, listen, I'll tell you, I used lidocaine for years and years and years, and it worked. I don't know why it worked, but it worked. And amiodarone all of a sudden came out. Do you think there was some sort of politics and money involved when all of a sudden amiodarone was the greatest thing ever and the AHA was pushing amiodarone?
No, that could never happen.
Never, right? Never.
Never.
The manufacturer of amiodarone probably didn't give any money to the Heart Association.
This is America, that would never happen.
So, I don't know. I want you guys to be smart paramedics. We're not teaching you cookbook medicine, right? We want you to think about what you're doing and know why you're doing what you're doing, right? Any questions about this? How are you going to know? Guess what? Many years ago, I would have given amiodarone to some of those patients. If you have the ability to do a 12-week, guess what? Look at that QT interval. And if that QT interval is already prolonged, do not give them amiodarone. Do not. What are the chances you'll take them to an ER where a doctor doesn't know this information? Well, if that's fine, let him kill the patient. You don't kill the patient. Yes?
What's our best treatment for WPW then? Because I remember we ran a scenario in Dynamic not too long ago where a patient had WPW coded and then we were told to push AMI.
Right. So,
Okay.
Propanamide, right? Well, so if the patient's in WPW and they're in an SVT, what is he saying? He's saying just shock them. If they're stable, just leave them alone. Can you use adenosine? No, you can't use adenosine?
That's what we were told.
So, for the patient,
Adenosine will kill the patient in WPW with AFib?
Hardison.
We don't want to give a calcium channel blocker.
But
We don't want to give a calcium channel blocker.
that's what we thought too, but we were just like, what about adenosine? He's like, adenosine will kill.
Who said?
Pennington.
It is the contraindication for adenosine.
slows the, it blocks the calcium, sodium, potassium channels.
It blocks everything. We hope that, but guess what? It's a very short-acting drug.
Okay.
So a calcium channel blocker would allow for the accessory pathway to go unopposed. Right? What? What's a whoa? You find something interesting?
Well, there's a huge discrepancy. We're both looking at, unless they're two different versions, but my drug profile says that adenosine, the contraindication is WPW. His says it's an indication for use.
How about, you want to know, I don't have my bag in here. You want to know where you should look?
Where?
Look at the AHA literature. What does AHA say for WPW? Right? Look at AHA.
If I remember correctly, you can't, it'll slow it down, you can see the underlying rhythm, probably.
He said 480. All right, let's take a break.